Thank you very much, Rishi. And I'd like to thank Rishi and everybody on the dais for making me a part of this course, which has been on for the last 3 years. And every time I go back, I learn a lot from the presentations. So in my talk, in the next 10 minutes, I'll be discussing a little bit about deep keratitis, not just deep isolated keratitis, but generally a keratitis which end up being deep as well as superficial. So here is a case. This lady, 53-year-old lady, had come to us 3 weeks post uneven full cataract surgery with a small lesion in the temporal half. And if you can see the OCT, you can see there is a lesion posteriorly below the stroma. And this is the clinical picture slit lamp, and this was the site of the main port, and this is more like a tunnel abscess. And these, although the patients usually are also on steroids post-surgery, and the clinical signs are suppressed, so these can be very tricky situations. And this is just an example of a case. And as I go ahead with the talks, we'll be discussing also about fungal. So we can come across many fungal keratitis. These are 2 cases. One is an aspergillus, one is a fusarium. Normally they are superficial. You debride them, you get the diagnosis, you initiate the treatment. The treatment goes on for 4 to 6 weeks, and they can scar down. So these are good case scenarios. They do not go deep. Sometimes you might come across, this is a lady who had come with such a lesion, and she had a history of symptoms since almost 1.5 months, and there was a streak hyperpion and a deep lesion. If you can see this slit picture, this is what it looked like, a small fluffy deep mass, as you can see here. So how do we go about treating such a case which does not have any anterior pathology? How do we go about diagnosing it? So the first thing is diagnosis. So any diagnosis of such a keratitis, even be it superficial or deep, is to first establish a diagnosis. So can the diagnosis be made clinically? It can be, but it's not always reliable, because the different bacteria, different bugs can create a different clinical picture every time. So as you can see in this case, this is a case of a gram-positive cocci. This is a case of a fungal. So in this case, maybe you can do a scrape and get an idea and start the treatment. But what do we do in such cases which are just deep? So in these situations, if you have access to technology like the confocal microscopy, it can be very useful to establish a diagnosis that yes, it's a fungi, and then initiate the treatment, be it topically or intracamerally, as we'll be discussing, and also for acanthamoeba. So these are 2 bugs for which confocal is very useful and can be used without any intervention, although it has its limitations. The other thing which one can do is also do a corneal biopsy. This is an invasive procedure, and in which case you can make a kind of a trap door, remove the lesion partially if possible, and then send it for histopath, establish a diagnosis, yes, it's a fungi. In this case, this lesion worsened despite the initiation of therapy and had to undergo a therapeutic graft for the treatment. But biopsy is also a good modality to establish a diagnosis and salvage the eye. One can also do an anterior chamber tap in case of a deep hyperpion to establish a diagnosis. I'll be discussing it as we go ahead along with the therapeutic interventions. So the second part is to initiate a medical treatment. So once you have a diagnosis, you start with the therapy. So what do you give? So if it is such a small lesion, again, it's a deep keratitis based on the picture. You cannot make a diagnosis unless you have a confocal. So in this case, based on the clinical picture, on the history of trauma and other things, we started the treatment empirically of antifungals, and fortunately this patient gradually responded over a period of 3 to 4 weeks on close monitoring. But this might not always be the case. So even if you are treating with antifungals, one needs to keep the following things in mind. That natamycin is usually the first choice, and it needs to be given at a very high frequency and to be tapered only after 4 to 7 days, not before that. And if it is not responding, then one can add other antifungals like amphotericin or voriconazole, especially if it is a filamentous fungi. But there are limitations to fungal therapy because it has a poor ocular penetration, poor bioavailability, and a lot of toxicity. And of course, in deep fungal keratitis, it becomes a challenge because the main fungal load is inside the cornea. Enough drug does not reach inside. So we need to add some systemic antifungals also. So these are the indications for deep keratitis, along with if there's a very large ulcer, if there's associated scleritis, if it's a graft which is infected, or if, of course, if there's endophthalmitis. So adjunctive procedures like anti-chamber wash and intracameral drugs come to the rescue in such situations. They need such severe keratitis needs such interventions. One can, of course, also do debridement, repeated debridement, which is supposed to be useful to increase the penetration of the drug, but it can also be a double-edged sword because it might also be causing more trauma. So coming back to this case, if you can see, this was a deep, she had already been on treatment for 1.5 months, and so we had to establish a diagnosis. In this case, what we did was we went ahead and did the AC tap. So with the AC tap is done under a full peribulbar block, and we make a side port paracentesis. And in this case, what we did was we normally use the 24 gauge or a 23 gauge visco cannula, what you use for your HPMC in your cataract surgery. Let me just move ahead. So one goes in and we can remove this particular lesion. In this case, fortunately, we were attempting to get it en bloc if possible without disturbing, without causing any spread or any otherwise into the antechamber, and it came off easily, and we sent it for culture, and it turned out to be a fusarium. This is the OCT picture of the same, just to give a different point of view that this is what it looked like. It was not involving the deep stroma as well. So this was something more of a antechamber lesion, and post resolution. Gradually, it took 4 to 6 weeks. We also had given intracameral amphotericin B later and continued with intensive topical medications. There was a lot of pigment dispersion and iris atrophy because of the inflammation caused due to the amphotericin B. But fortunately, it resolved. So these are just case situations in which one can use antechamber wash along with amphotericin B injections, which can resolve with these deep cases. So what are the indications when you would like to use intracameral antifungals? Would be when it's not responding to any medical therapy. There's a very thick hypopion, endothelial exudates form the bulk of the lesion. And what do we do is, dose of amphotericin B used is between 5 to 7.5 in 5% dextrose, but it doesn't always work. In this case, as you can see, there was some reduction, but then after 7 to 10 days, it again started increasing. So sometimes you might need to add more things. So Professor Namrata Sharma had done a study in 2008 in which they started using intrastromal drugs. Voriconazole had come in and they were using that, and they showed some promising results that it might be useful to give intrastromal voriconazole as well. I think in the interest of time, I'll just skip this video. But later on, they also evaluated the role of intrastromal voriconazole versus giving voriconazole topically, because voriconazole has a good penetration. And what they found was that the intrastromal injections did not offer any beneficial effect. So the take-home message here is that intrastromal drugs as such would not be required for such cases and for such drugs which already have a good penetration. And the rest part would be that if it does not respond, one would need to do a surgical management, which Dr. Rishi will be discussing in the coming up presentations. So these are just a few cases in which we had to, initially it responded, there was a decrease in the superficial lesion, but the deep lesion eventually perforated, and they had to undergo a graft. This is a view of the corneal button gross post-surgery. As you can see, the perforation from the other side. So to summarize, I think the first thing for any keratitis, be it deep or superficial, is to try and establish a diagnosis. You do scraping, you do corneal biopsies, you do an AC tap, you do a confocal, whatever tools that we have. Intracameral drugs definitely seem to have a therapeutic role in deep keratitis, especially fungal, but one needs to keep in mind that they do also have toxicity, so they need to be monitored carefully. One should have a lower threshold for surgery in such cases, because these can become like cases which we might only be able to save the eye, not the sight. And not all of them are deep keratitis or nightmares, as you can see in this case, in which with just one amphotericin B and topical drugs over a period of 4 to 5 months, the lesion eventually resolved. I think that brings me to the end of this talk. Thank you very much.